Brought to you by Gilbert Hospital in Florence and Anthem Hospitals. I'm Dr. Ann Borick, board certified in internal medicine, and I'm here to keep you up to date on the latest information pertaining to your health and well-being. Welcome to DocTalk Radio, sponsored by Gilbert Hospital and Florence Hospital and Anthem. Joe, we have a great show in store today. We have a cardiologist in the studio. And I just want to tell those folks listening, please don't hesitate to call in 480-745-1033. I want to get right into it because there's so much to talk about. Dr. Rajdeep Gaitonde is a cardiologist and an electrophysiologist. He's an electrician of the heart. Raj, thank you so much for being here.
Thank you for inviting me.
You know, tell us a little bit about your background and your specialty as an EP specialist.
So, my proper title, I guess, is a cardiac electrophysiologist. A lot of people will say, well, exactly what is an electrophysiologist?
Right.
Because people know what a cardiologist is. So essentially, I always like to simple things, make things more easy to understand. So I always like to say, hey, think of the heart as a house. Every house has plumbing. Every house has electricity. So a lot of individuals have heard of interventional cardiologists that open up arteries by angioplasty and stents. Well, I do the electrical work. So when people have irregular rhythms of the heart that they need to get under control or eliminate, people need pacemakers, people need defibrillators because they've had a history of cardiac arrest. Well, all those electrical needs are met by myself. So yes, I did my internal medicine residency training, followed by cardiology fellowship, followed by an additional 2 years in electrophysiology.
So you actually are a plumber plus an electrician. So you actually, did cardiology.
I did cardiology too.
Okay, okay. Dr. Gaitonde is one of my colleagues. We've worked, for years in the hospital together, and so it's really great to have you here. I can tell you that your patients love you, and you really do a great job. So thank you. You know, probably one of the most common reasons that I would consult you or have a patient, come to see you would be for syncope, passing out, those kinds of things. Do you want to, kind of give us some information about, the things that you see most commonly in your office?
Well, things that I see very commonly in the office is I'll have patients refer for syncope, which is a fancy term for getting dizzy, lightheaded, and passing out. Also, I'll see patients secondary to palpitations, feeling their heart race, irregular rhythms, and then also referrals for things like pacemakers and defibrillators, which we can talk about a little later. Right. Syncope is just a very broad topic. It's, essentially patients getting lightheaded, dizzy for whatever reasons. It's actually a rather frustrating diagnosis in the sense that it's difficult sometimes to pinpoint what is the exact underlying etiology of why the individual is passing out. A lot of times it is cardiac in etiology, and if it is cardiac in etiology, it actually portends a worse prognosis. A lot of articles, such as the one that got published a few years ago in the New England Journal of Medicine, portended that an individual was passing out secondary to cardiac reasons long-term, but it had increased morbidity and mortality. So a lot of times I'll have physicians who have tried to do a workup in syncope for whatever reasons and done different types of testing modalities, and then they're still not exactly clear. A lot of times patients will be sent to neurologists. Is there a neurovascular sort of etiology? And then a lot of times I'll get patients, they're not really sure what the etiology is, so could it be something electrical? Example is I had an individual who had a history of coronary disease, had a myocardial infarction, and had stenting done. His function of the heart was borderline. It wasn't completely abnormal, but he was having episodes of passing out quite a bit. Nobody could see why. So I did a study called an electrophysiology study, which is essentially looking at the electrical system of the heart using catheters in a microsurgery aspect. And I found that this person had easily inducible ventricular arrhythmias, i.e. when you see on TV shows like Grey's Anatomy and say clear and they're shocking the patient, well, hopefully they're doing it for the right reason. A lot of times it's because they have these ventricular arrhythmias. Ultimately ended up putting a defibrillator in this individual, and about a week or two after I had seen him, or after I had implanted him, he had a similar episode getting lightheaded and dizzy, but this time he actually got a shock. And he actually got a shock because he was about to have a cardiac arrest. Wow. And so that's obviously one extreme. There are other things which are more benign that could be causing this, but that's just an example of workups that we do for complex syndromes.
So, somebody comes into your office with syncope or lightheadedness. What would be I mean, you don't take everybody to an EP study, right?
No, it's, what we were taught in medical school, which you can obviously correlate with, is that the biggest thing whenever you see a patient, spending time sitting down with them and getting an accurate history and physical, listening to actually what the patient says, and listening is honestly the key.
Right.
Based on the history that the patient describes to you, are they getting lightheaded, dizzy because of positional changes? Could it be because of blood pressure issues? Are they getting lightheaded or dizzy because they feel their heart racing? Based on the symptoms and the actual triggers that they're exhibiting, that's how I kind of curtail the type of workup. In this gentleman, why I went with the electrophysiology study is because he'd have on telemetry, on monitoring, he was having bursts of these irregular rhythms, these ventricular rhythms. He also had a history of a heart attack in the past, so his heart function wasn't normal. So these were all steering me down this more invasive workup. And because of all of his risk factors and what we saw in the initial data that was worked up, that's why he was more amenable to do something more invasive. And because of that, we actually found the reason why. Other individuals, if it's just simply like lightheadedness or dizziness, another test we do is something called a tilt table.
Yeah, I was going to ask you about that.
A tilt table essentially looks for a couple of things. Essentially, we strap an individual to a table and tilt them to 70 degrees, and we monitor blood pressure and heart rate. Now, if it's strictly because of blood pressure issues, when you tilt the individual, you'll start seeing their blood pressure drop and their heart rate increase, which is physiologic. But sometimes individuals have low blood pressure to begin with, and they're more susceptible to positional changes. There's also another thing it looks for, something called neurocardiogenic syncope. What essentially that is the interaction between the nervous system and the cardiovascular system. Now, all of us, if we stand up still for a prolonged period of time, what happens? Gravity pulls blood down to our lower extremities. Now, the only way blood really gets back is basically the action of skeletal muscle pumping the blood via the veins back into the heart. Now, if you're standing for a prolonged period of time, blood's just accumulating and pooling in the lymphatic system. Then what happens is the heart starts pumping because it's trying to get more blood flow out. Now, there are mechanical receptors in the walls of the septums of the heart which start getting activated. And when they get activated, the body's thinking, oh my God, my blood pressure's actually high. So what it does is a paradoxical reaction, and it actually causes the heart rate to drop. Then the heart rate drops, and then your blood pressure truly drops. They call that a cardioinhibitory, meaning slow heart rate, vasodepressor, blood pressure dropping. And that's because of an augmented reflex that all of us have. If you strap any of us to a position, a standing position, we will eventually pass out. But some individuals have an augmented reflex that we can use certain medications to kind of stabilize that reflex.
Right. That's interesting. So, sometimes I'll see people come in standing, at a wedding. It's very warm, and they're standing for a long, extended period of time, and they pass out. So it's that mechanism.
That's potentially a mechanism. You see a lot of times people standing in church.
In church and those kinds of things.
Kind of a closed environment for a long period of time, older individual that gets kind of woozy, lightheaded. And sometimes, like again, a history such as that kind of gets you on that pathway. What kind of modality is best? We were always taught that if you're going to do a test on any kind of patient, make sure you already know you have an idea what the answer is. You're using the test to basically further your hypothesis.
That's really interesting. And that mechanism doesn't mean there's a bad pathology.
No,
it's just an augmented physiologic response.
Augmented physiologic response, precisely.
Fantastic. That's interesting. Don't forget, call in 480-745-1033. I'm really interested to hear what folks out there have to say and ask you and question, because there's so much really to talk about. Atrial fibrillation, is a topic. Do you want to kind of talk a little bit about AFib and how that differs from ventricular tachycardia?
Right. So atrial fibrillation is probably one of the most common arrhythmias that, as a society, we get. About 30% of individuals as we age end up with atrial fibrillation.
Can I get you to tighten in just a little bit on that microphone? I'm sorry. Thank you. Perfect.
Atrial fibrillation, like I said, is about 30 or so % of the population as we age gets atrial fibrillation. Wow. What that is basically, think of it as a chaotic rhythm originating in the top chambers of the heart. And the risk of it is basically twofold. One, it's an annoyance. Some people feel it because their top chambers are beating rapidly, followed by the bottom chambers, the ventricles, beating rapidly, and they feel that, and that's the true palpitation they're feeling. Other individuals don't feel it. It's amazing that some people are exquisitely symptomatic, others are not. So from an annoyance standpoint, you have that as well.
Right.
From a morbidity and mortality standpoint, when you don't have a nice squeeze of the top chambers of the heart, you can get pooling of blood, as you've seen. If you ever see blood gets pooled up, like in a tube or a vial or whatnot, what happened? It clots up, it congeals. If it didn't, every time we got a paper cut, we bleed to death, which would be a problem.
Right.
So we all have this natural clotting cascade, and when you have areas of the heart which aren't squeezing properly because of this chaotic rhythm, it increases your risk of blood clots developing, which can lead you to developing strokes and whatnot. So it's actually a twofold issue, one from symptoms and one from your risk of stroke.
And so that's really why people with atrial fibrillation, we have on Coumadin.
Right,
you know,
or
those
nowadays
kinds
it's Pradaxa or Xarelto, depending upon what we call a CHAD score, CHADS. And that's a moniker that we use that describes the risk factors. 1, C, congestive heart failure, H, hypertension, age over 75, D, a history of diabetes, and S is for stroke. You get 2 points for that. And based on your numerical value, it tells you, is full dose aspirin good enough, or should you be on something like Coumadin, Pradaxa, Xarelto?
Very interesting. And the whole idea is to prevent that blood clot effect so that we prevent strokes.
Right. We don't want the blood to pool, thicken, and therefore increase our risk of stroke.
Interesting. That's great. I know that there's some questions coming in. You know, pacemakers is another huge, huge topic. And for those of you listening, I want to just direct you to a website that we're not going to actually go to live right now, but the website is www.AAEP, so AAAEP.net.
Right.
And this is Dr. Gaitonde's website that actually has, maybe you can explain it.
Well, that's the website for my my practice, which is Arizona Advanced Arrhythmias. Again, www.AAAEP.net. And if you go to that website, it has information about myself, but it also has information about various topics regarding electrophysiology. I'm a person who likes to see things. I'm a very visual learner, so I also have a lot of drop-down animation that shows you different arrhythmias, shows you information about pacemakers and defibrillators, and it's very simple to navigate. I had both my mom and dad navigate it before I launched it, and my mom's not very computer savvy, so if she could figure it out, I think anybody can figure it out.
And the reason I bring that up is because, you know, if we're going to talk about pacemakers, this is a great way to actually see, you know, what you're talking about when you talk about, you know, putting the wires in and feeding it and so forth.
And my patients will always attest whenever I sit down in consultations, I show them the animation, but I'll also draw very crude Picasso-like pictures of the heart to describe what we'll be doing.
Right, right. So pacemakers, do you want to, you know, just kind of...
So pacemakers, you know, people are familiar with pacemakers. So what is a pacemaker? Essentially, it's a device which has either 1 or 2 leads in the top and bottom chamber of the heart, and basically it ensures that you have a heart rate. Certain individuals, they have what's called bradycardia, their heart rate's too low and they get lightheaded and dizzy. Other individuals have a problem between the connection between the top and the bottom chamber, and they go into a phenomenon called heart block. So the top chamber beats, but cannot tell the bottom chamber, which pumps the blood, to beat. In those situations, they get lightheaded and dizzy, and they call that heart block, and we put pacemakers in for that. Pacemakers now are basically the size of a Kennedy $50, a lot smaller than when my own grandmother had a pacemaker placed. Common misconceptions are microwave ovens. I always get that. Now, back in the old days when pacemakers were first invented, you know, microwaves were almost like thermonuclear devices with no appropriate shielding. Nowadays, you know, I always tell my patients, you can turn the microwave on as long as you don't sit there hugging the microwave or trying to step inside the microwave. You should be fine.
Right. That's interesting. You know, you said 1 or 2 leads.
Right.
What's the indication? What's the difference? When do you choose to do a 2-lead versus a 1-lead?
It's a very good question. Depends on the etiology. So some people, their God-given pacemaker, the sinus node, doesn't beat fast. So in that situation, you want to pace the top chamber, and which will conduct to the bottom chamber. And in that situation, you can put 1 lead to the top or 1 lead to the top and to the bottom. Other people who are sometimes in chronic atrial fibrillation, it's just that their heart rate's slow and you don't really need synchrony dichotomy between the top and the bottom. Some people will just put a bottom lead. So it's very specialized based on the indication of why the said individual needs a pacemaker in the first place.
Okay, good. Joe, do you have a question there?
A couple of them here. Jenny, 42 years old, fairly healthy, she said, from Phoenix. I notice when I smoke, my heart seems like it beats hard. Is this normal?
Well, Jenny's a young lady, and she should quit smoking, first of all, not just from a cardiac standpoint, but from a physiologic standpoint. Now, with smoking, does it beat harder? You know, you have stimulants in smoking, which could potentially get your heart racing. Obviously, smoking also increases your blood pressure. It causes constriction of vessels. So you can have an increased incidence of hypertension, increased incidence of palpitations. So is it abnormal? No.
So it's a normal physiologic response, but it's not a healthy thing to do.
Not a healthy response, obviously. And if you're young at 42, you might as well quit now.
Absolutely.
Next question, Brenda Phelps, Little Rock, Arkansas, 62-year-old female, diabetic, otherwise healthy. I've been out of exercising for a while. I need to lose about 100 pounds. Bought a treadmill, tried it yesterday, did 3 minutes, and was done. Is this safe, or should I get tested for something first?
Good question.
Well, whenever an individual is going to have going from really no activity to trying to attempt a strenuous activity, a lot of times I will recommend seeing a physician, a primary care doctor, and then deciding, a hospital, deciding do they need to see a cardiologist after the fact. Now, but think about it from this standpoint. Let's say you don't do anything baseline, and now suddenly you're on a treadmill. Your heart's not used to it. It's completely deconditioned. So it's very normal. Your heart's going to the rate will jump exponentially versus a nice smooth run. An example for myself is when I had taken a year or so off because I was so busy in training, I didn't have a chance to go back to the gym. I noticed when I went back to the treadmill, my heart rate would increase really rapidly. But once I started exercising more, getting more cardiovascular aerobic activity in my regular regimen, I noticed a couple of things. One, my resting heart rate dropped because I was more in shape. Number two, what else happened? It took longer for my heart rate to go up because it was more conditioned. I can tell you stories of patients that I've come across over at where I trained, Indiana University. There was once a patient who had a heart rate of 38 beats per minute. He had no symptoms whatsoever. And people are like, is that normal? Well, this gentleman happened to win the Tour de France 7 times in a row. Well, now obviously they've been taken away from him. But at IU University, we did cure Lance Armstrong from his testicular cancer. And obviously an individual like that who's in such good shape. I'm a huge football fan. So I used to run to one of our hospitals, Methodist, to see all of the college kids come in for the combine.
Right.
And these kids had resting heart rates in the 50s. You know why? Because they were in great physical shape. But I always, like I said, getting back to Brenda, I always say, if you're going to start a strenuous regimen, it's a good idea to see your primary care physician just to make sure that you're not having any red flag symptoms that potentially could cause problems on your road back to health.
Absolutely. Dr. Gaitonde, can you talk about blood pressure? The heart rate is interesting, but what happens with blood pressure during exercise?
Well, normally physiologic, you'll see your blood pressure rise. It's just normal physiologic response. Now, obviously, you'll run across patients who have a high resting blood pressure, and then it gets even higher and higher.
And that's not good.
And that's not good because obviously high blood pressure portends a lot of problems such as stroke, kidney failure, heart failure as well. I was amazed when I went to, just talking about blood pressure in general, how most of us don't even pay attention to that. And there are certain groups of populations you get really concerned about. When I was in Indiana, we had a large black population. And I would be amazed at how many young 20-year-olds and 30-year-olds who I'd see on my service on dialysis because of high blood pressure issues. And so, that's one thing that, screening is always is better, primary prevention is better than having the problem and then having a high blood pressure, having heart failure, and then having to see me for a defibrillator later on.
Exactly. It is the silent killer. And we know that blood pressure, it doesn't hurt, it's not painful, but you can be walking around and have a blood pressure that can be, slowly, day by day, tearing your body down. And then you end up seeing this guy, and that's, that's not where you want to be.
I'm always happy to see you, but, you can spare yourself.
Exactly. I remember clearly in the hospital, in the ICU, we were sitting there talking about a patient that we had together in the ICU, and it happened to be somebody that had broken heart syndrome. And can you just explain a little bit about that? Because this is a fascinating cardiovascular syndrome that a lot of us don't realize really exists.
So broken heart syndrome actually got coined broken heart by a New England Journal of Medicine article that actually came out on Valentine's Day. The exact year, I want to say it was around 2003, 2004, because I remember I was just starting my general cardiology training. And what it is the actual term is also Takotsubo's disease. Now, Takotsubo, what that is, if you want to Google an image of it, Takotsubo is basically a clay pot used to capture octopi. Not that many of us do that, especially in Arizona because there's no water.
Right.
But anyways, the reason why it's named Takotsubo is when you do a ventriculogram or doing an echo on a patient and you look at it, the apex or the tip of the heart kind of balloons out and it looks kind of like this clay jar versus the more basilar portions of the heart still have the normal squeeze. Now, broken heart syndrome refers to this heart failure, which is and many times transient, but these patients will present with electrocardiographic changes on their EKG with chest pain, and if you see their EKG, you're like, oh my god, we need to take them to the lab, to the cardiac cath lab to cath them, make sure they're not having a heart attack. We actually did a series of studies when I was a fellow at IU that got published showing that these patients presented like an acute myocardial infarction. Right. You open up, you look at their arteries, they're completely normal, but you see this apical ballooning. Now, the reason why it's a high adrenergic, stressful situation basically stuns the myocardium. And basically with medications, it actually, a lot of times you'll see this resolve within a few months.
So stress, anxiety, like severe trauma, somebody loses, a loved one, loses their job, those kinds of things, without our consent, physiologically can affect our body.
Right, a lot of things happen without our consent. And you'll have the, obviously your body's a temple. So if you're having these high stress, high adrenergic situations, you can actually have, a negative effect on the heart. And for the majority of patients that we saw who actually had a true Takotsubo's, it was almost like a diagnosis of exclusion with proper medication. And within a few months, we'd see these
get back
resolve.
Right.
A lot of times people undergoing, a lot of females undergoing surgeries or high stress situations, and it was called broken hearted syndrome. And
right, because of the stress.
Because of the stress,
of
precisely.
Yeah. That's interesting. Joe, another question?
James, Fort Lauderdale, 47-year-old male, about 50 pounds overweight. How can I test my resting heart rate, and what is normal range for myself?
Well, basically just taking your pulse, at rest, counting how many beats you have in 30 seconds, times it by 2, or 15 seconds, times it by 4, you can get a resting heart rate. Now, what's a good resting heart rate? Now, basically, it depends on the individual, how old they are, what kind of shape they're in. Resting heart rates, we say the heart rate ranges from 60 to 100 beats. If it's lower than 60, we call that bradycardia. If it's higher than 100, we call that tachy, Latin for fast. Now, if a person's, in decent shape, it should be around anywhere from 60 to 70, maybe 60 to 80 beats per minute. As far as your maximal heart rate, if you get 220 minus your age times 85%, that's basically your predicted maximal heart rate. So for me, in my mid-30s, if I'm exercising, I should get my heart rate up to 150, 160, which when I'm on a treadmill, that's what I aim for.
So that's good. Again, 220 minus your age gives you the actual number, and then times it by 85%,
to get
which
your
is
predicted maximal heart rate.
Right.
You want to get about to 85, 88%.
So when you're exercising, in order to know that you're actually doing enough work to really strengthen the heart.
Yeah, because obviously it's going to change. If you're 16, you can get your heart rate up to 180, and that's normal.
Exactly.
But if you're 70 years old, if your heart rate is 180 beats per minute, that's abnormal, obviously.
Exactly. Very good.
Merrill J. from San Francisco, 50-year-old male. I have an occasional tightness in my chest, but goes away after I take a big breath. Happens every few months. Been happening since I was 15 years old or so.
There's all kinds of different things that can cause cardiac or can cause chest pain. If you look at what's in that area, you have the heart, you have your lungs, you have your musculature, you have your GI system. Obviously, you're always concerned about the cardiac because that's the one that could harm you the most. Now, if you've been having pain with, that seems to be clear with a deep inspiration or whatnot, since you were 15, is it cardiac? It's hard to say. We look at a lot of different things. How does it? Is it increase in frequency? Are there certain types of triggers? I.e., does exercise increase it? Or do you have these episodes at rest? Do you have these episodes with positional changes, with deep breaths? Sometimes people will be doing a lot of heavy lifting and have musculature strain, and then when they start breathing more, they have pain. People who have like a pneumonia, sometimes they'll get pain. Sometimes people get indigestion, they get pain as well. Or it could just be this pressure-like sensation with activity, which we call the Levine sign, which is your classic angina. So it all depends on the exact type of presentation, how long it's been going on, and more importantly, what's your risk factors? Do you have risk factors for cardiac disease? Do you have a family history? How we would treat somebody who's 20 years old having pain with no risk factors and no history is completely different than the workup we do for somebody who's 80 years old with multiple different risk factors.
Absolutely. Again, this is our DocTalk radio is really intended to be informational only. We don't really want to diagnose over the phone. So, so callers just kind of keep that in mind. But keep the calls coming in because this is good conversation. There's defibrillators in the community, and I just wanted to kind of hear your insight about what you think about that, and what the studies show in terms of the defibrillator.
Well, there's been a lot of studies, especially like in the Seattle area, of looking at public access defibrillators in reducing your incidence of cardiac death. The biggest thing you have to always realize is that there's one thing to have a defibrillator, it's another thing to have somebody able to use it on an individual.
Right.
And just because it's available, if you're by yourself and you have a defibrillator and you have a cardiac arrest, how are you going to put it on you? So those are, a lot of communities, even in Indiana, they would have one available, like in a central clubhouse location. But that also behooves it that the family could be able to get there and bring it back and know how to use it. If an individual is by themselves, that makes it a little bit more difficult. In theory, it makes sense to have more access, especially, if you have to wait for 911. Of interest, though, these actually work better in high-volume type centers, places such as airports, where there's everybody, you have cameras all over the place, people all over the place. Also, interesting enough, in casinos. Because obviously you always have somebody watching you to make sure you're behaving yourself in the casino. And I've had plenty of patients in our Native American casinos that we have out here who have passed out. They've gotten prompt service and prompt defibrillation because there's somebody always watching. So, in those type of high volume settings where you have a lot of people keeping an eye on a person, those have saved multiple lives.
That's really interesting. Is it mandatory in the casino? I would think that...
I don't know if there's any federal law mandating it. That I honestly don't know. Okay, but you've seen, at least me personally and anecdotally, I can tell you multiple stories of individuals who have been saved because they were gambling. It's a great place, all jokes aside, it's a great place to have a cardiac arrest is in the casino.
Right, because you're being watched.
You're being watched.
Speaking of sudden death and dropping, I want to just kind of turn to athletes, high school kids, and looking at, we do monitoring and we do these history and physicals for sports.
Right.
And, is an EKG recommended in everybody? Is an echocardiogram to look at, hypertrophic cardiomyopathy? What is your take on that?
These are all questions for, I have friends of mine and colleagues of mine who specialize in sports cardiology.
Right.
And these are all debatable because you're looking at the cost efficacy of actually doing screening modalities. In Italy, for instance, everybody gets screened with an ECG. They find it maybe cost beneficial, and there are certain other arrhythmias that are more predisposed in individuals of in Italy or Greek islands or whatnot. I can go into all kinds of different syndromes. Again, as far as what the as far as how effective it is here, that's why a lot of times we basically have the sports physical auscultating, listening to the individual, listening. Does their heart, do you hear any murmurs? Do you hear anything that would make you concerned? Is there a history elicited from said young athlete that would make you suspicious.
Right, family history.
Family history, you know. Cardiac death in general is the #1 killer in this country. Over 350 to 420,000 die each year. Now, now obviously that's for a variety of different reasons. Do we see athletes, having cardiac arrest? Of course, we've seen that. Now, the actual incidence obviously is less than if you had an individual who's had previous heart attacks, heart failure, those kind of things. But to get back to as far as screening ECGs and screening echoes, it goes back to the cost-benefit ratio, and I think that's one of the things that's been debated upon. And there are other individuals who are far more knowledgeable in this that could give you more in-depth answers.
Right, Gilbert Hospital, the sponsor of the show, they do TOPS. They do a great program every year where we screen probably over 1,000 high school athletes, free of charge. And every single one of them get an EKG, and if indicated, an echo machine is right there, on the field or in the area where this is being done, usually in the school gym or wherever. So it's a great program. Now, whether or not that's indicated in everybody, I don't know, but at least I do know that they're doing that.
And I know that like certain athletic programs, like one of my friends who's a cardiologist in the Carolinas, he actually is setting up has a sports cardiology clinic, and they'll actually send athletes from the local colleges will go there, and they will get these workups. Now I can't answer if an answer to the question is everyone indicated, but like I told you, like even in the NFL Combine when they used to come to Indianapolis, every athlete would get an EKG and echo. So now, is that cost effective? I can't tell you the answer to that. But a lot of times, based on history and physical, the individual can tell you what's going to be higher yield.
Exactly. Joe, I know we have a couple questions there.
Let's see. Let's start with Betty Lou Sims from Muncie, Indiana.
There you
Muncie,
go.
Indiana. Ball State University.
Yeah, there you go. Never had a blood pressure problem, but every time I go to a pharmacy and check on those machines, they're always high. My doc says, don't worry about it, they're false. Why would we have those machines?
Well, I don't necessarily know they're false. One thing I always tell my patients too, let's say they're, we always check vitals, and they say, well, doc, my blood pressure is different at home than it is when you check it. Well, in those situations, I always say, well, you know what, bring your blood pressure cuff to the office, to your primary's office, whatnot, and calibrate it. Now, are the machines, I can't say that every single blood pressure cuff in any kind of Walmart is incorrect, but sometimes maybe they need calibration. So I wouldn't write it off like that. And a lot of times too, some people get what's called white coat hypertension, that they come in, see a doctor, and their blood pressure's higher than it runs at home because they're anxious and nervous. That's understandable. But of note, those individuals who actually have a higher blood pressure with quote white coat hypertension, that's actually still a sign of impending high blood pressure.
Absolutely. Betty Lou, my recommendation too would be don't ignore it. Absolutely don't ignore it. Maybe stop by a firehouse or something. Get your blood pressure checked maybe on a different machine. Go to your primary care doctor. But definitely don't ignore it if your blood pressure consistently is being read high, in Walmart or Walgreens or something like that.
Then we have Tom from Mesa, Arizona that says, I take an inhaled mist for a lung condition, not asking for a diagnosis, but do inhaled medications have negative effects on the heart?
Well,
good question.
It depends on the type of inhaled. Is it an inhaled steroid? For people who have have like a asthma, COPD. Is it some sort of sal-Advair combination, or is it just a pure beta agonist? For opening up airways and dilating airways. Now, pure beta agonist, beta 1, beta 2, like for instance albuterol, for instance, that does it have a negative effect on the heart? Well, not necessarily a negative effect, but it can stimulate those beta 1 and beta 2 receptors that get your heart rate going. So it's not unusual when people get nebulizers, or just take an inhaled, one of the inhalers, which is like an albuterol inhaler, to feel their heart rate go up. That's not abnormal. In fact, I've had patients whose heart rates go up too much. Then there's actually another leave albuterol, which is an enantiomer. Zopanex is the brand name, which doesn't necessarily cause as much of a beta 1, beta 2 effect. Now, the data for that is more in pediatric populations, but, anecdotally for adults as well. But for a long-winded answer to a short question, is it going to be negative? Not necessarily.
Right. It's not dangerous. In fact, when we do see that heart rate go up, that's a physiologic, response. Just one more comment about prednisone. If it's an inhaled steroid, sometimes steroids, and I tell my patients, if you're going to start on steroids for, let's say you have a bad back or you're on a Medrol dose pack, you see that. I mean,
right,
you can have heart rate.
And I've also seen, in going away from cardiovascular, I've seen inhaled steroids causing like osteoporosis. I'm sure you've seen that as well.
Absolutely.
And there's been written reports about that as well,
Right.
because I guess you get some assimilation from the body systemically.
But it causes that jitteriness that sometimes...
High dose steroids can cause jitteriness
Right,
and shakes as
shaking.
well, steroid psychosis, that we've seen.
Right. That gets me to talking about panic attack. A lot of times people are diagnosed with panic attack, palpitations, anxiety, when in fact there may be an underlying organic problem. Have you seen that? What's your experience with that?
One of the most common things I'll see patients for, or arrhythmias, palpitations, and I'll see. There's a great story I have of a patient who's 80-something years old, and she was diagnosed in her early teens with anxiety because she would feel her heart race, and in the past she was given Xanax or told her it's okay, it's nothing to do with your heart. One day she was actually getting a cardiac catheterization done, which ended up being normal, but she had a quote panic attack and her heart rate was racing in the 140s, 150s. And this was actually an arrhythmia, a supraventricular tachycardia. I actually took her to the lab, we did an electrophysiology study, I ablated her abnormal conduction, and she never had an episode again. And she's like, "Doc, I don't have panic attacks anymore." Now, who's to say? Sometimes what came first, the chicken and egg? You could have an arrhythmia, not know what it is, get worked up about it, and yes, quote, have a panic attack. So I've seen a lot of times when people are feeling their heart race and they've always been told they have panic attack, and sometimes, you have underlying arrhythmias, which are actually causing symptoms.
Right. I want to talk more. I know there's a question we're going to get to, but just keep in mind, I want to talk a little bit about SVT and ablation and that kind of thing. So I think that listeners will be interested to hear about that. Joe, do you have a question?
Yes. Kelly Lynn Myers, Louisville, Kentucky, says, I'm 27 years old and pregnant. I feel very anxious and I get terribly out of breath. Should I be concerned? My primary doc says pregnant women get all kinds of ailments, not to worry. Should I get a second opinion, and what should I have tested?
As far as pregnancy is concerned, a couple of things. Obviously, you have increased blood volume and increased hormonal milieu that's in the body. Now, there can be your symptoms could be nothing, but also other things you can consider is that it's not abnormal for pregnant females to have arrhythmias themselves because you have increased right atrial stretch secondary to more blood volume. So it's very common that I'll have patients who will present with arrhythmias because that's exacerbated by their pregnancy. And then I'll see these patients sometimes after the fact, when they've delivered and they've had this history of rapid heart rates. And I'm like, well, did you ever have any when you're pregnant? And they're like, it's funny you would ask that. So sometimes it's not unusual to have arrhythmias. Now, as far as shortness of breath, it depends on how short a breath she is. Now, obviously, I'm not there, so I can't assess her. But one can, you can have cardiomyopathies secondary to pregnancy and postpartum cardiomyopathies. I've seen females who have actually gone into heart failure during pregnancy, and once they delivered the baby, we've done echoes, and their heart function would an ejection fraction, we call it. Normally the heart function is 50 to 60%. The ejection fraction gone down to 15, 20%, and it's what we call postpartum cardiomyopathy. We put them on medications and resolve, but we always advise those individuals not to get pregnant again because they were at high risk of having heart failure and potentially having a cardiac arrest. So, sometimes when I have patients who say, if they're pregnant having arrhythmias or really short of breath, it may not be a bad idea, depending on how bad her symptoms are, to maybe see a cardiologist, get an echocardiogram, make sure the heart functions normal. And again, none of this is to scare said individual, but sometimes these are things that you can have with pregnancy. And obviously, I'm describing more worse situations.
Kelly, other things to look at would be swelling. Some of the other signs of congestive heart failure.
Lower extremity edema. But I could say difficulty laying flat, but obviously that's probably difficult when you're pregnant as well. So,
exactly. Right. Let's talk about cardiomyopathy. Alcohol. There's a lot of people talk about alcohol and the positive effects of red wine and so forth for the heart, but when it comes to the heart muscle, as an electrophysiologist, what do you say? What is your studies and what do you recommend?
Well, the problem with alcohol is that obviously some individuals have issues with alcohol as far as alcohol abuse, and it's hard for me to advocate something when potentially person could have an addictive personality and or develop an addiction. Now, do I enjoy a glass of wine with dinner? Of course, I'm a big Cabernet fan. But is there benefits for alcohol? Yes. My philosophy in life, anything in moderation, just like the Greeks told us. And so there is benefits for, as far as polyphenol complexes, the vasodilators, the French paradox that we've heard of as well with drinking alcohol. But alcohol can also be a toxin and have a toxic effect. Now, the amount of alcohol that's going to be toxic, nobody knows. For instance, when I was at IU, we'd see these college kids coming in after doing keg stands and having drinking way too much beer in atrial fibrillation. We call that holiday heart. You drink too much, and it puts you into atrial fibrillation. Likely these were transient; they get out of it. But you can have alcohol, too much drinking alcohol, cause arrhythmias like that. Also, too much alcohol can actually weaken the muscle and act as a toxin. At a young 30-something-year-old patient when I was a fellow at IU who came to our county hospital in congestive heart failure. Did a cardiac cath on him. All his coronaries were normal. His blood pressure actually was fine too. But then he got sent to my clinic, and I was talking to him, and I was like, "There's got to be more to this." So I asked him, any history of recreational drug use? There was a big crystal meth problem up in Anderson, Indiana. Though he wasn't doing any of that. No cocaine. I asked him, "What about drinking?" He's like, "Yeah, I'm drinking about 3 24 packs a week." I'm like, what? And I was like, and I'm just thinking to myself, that's a lot of volume. You're drinking anywhere from 8 to 12 beers a day. And I'm like, I asked him why to do that. He's like, "Oh, my girlfriend broke up with me." Right. I'm like, well, there are better ways to handle that. But I told him you need to stop drinking completely. So we put him on some medications, but he actually stopped drinking completely.
Heart muscle got better.
Within 3 months, his heart function was normal. I didn't have to put a defibrillator in him. But that's an example. Now, obviously, he drank a lot, but the exact amount of alcohol that will create it, nobody really knows for a fact. But heavy alcohol use is known to cause arrhythmias, as well as known to be a toxin to the muscle and cause congestive heart failure as well.
That's interesting. That's very interesting. I know Joe's writing over there. There's some questions. SVT, supraventricular tachycardia, you had mentioned it. You talked about ablation. Kind of give us a picture. What exactly is that, and what do you do? What is an ablation?
So an ablation is a fancy term for basically cautery. So if you look at the heart, the outside of the heart is where you have your coronary vessels. Those are vessels which are stented, or bypassed if they're blocked. The inside portion of the heart is where your electrical circuits are. Now, arrhythmias is just a broad term, and meaning, fast heart rates or whatnot. Supraventricular meaning is coming from the top chambers of the heart. And sometimes people will have these episodes, they notice their heart races, makes them lightheaded and dizzy. Now, an ablation refers to basically kind of almost like a microsurgery. Basically, through IV punctures in the lower leg while the patient's sedated, I feed catheters, which are plastic wires, into different portions of the heart and basically map out the electricity. And we can even do computer animation to show the activation pattern of certain irregular rhythm. If you have, and going back to basic science, basic chemistry, physics, if you have a circuit and you break the circuit, you can't propagate electricity. So it's the same kind of adage. You're cauterizing an affected portion of the circuit to try to terminate the circuit so electricity can't propagate itself. So when you look at something in cardiology which is really curative, ablation therapy actually gets rid of it.
It's one of the few that, really is curative.
It's really curative. But when you have a heart attack and you open up the arteries, you didn't cure anything. You prolong life, which is obviously a good thing. My dad's had bypass surgery, and he's still living 20 years after the fact. But that didn't reverse the disease. With an arrhythmia, you can actually get rid of the arrhythmia and potentially never have it again. So you can actually cure the individual of said arrhythmia.
Interesting. That's great. Joe, what do you got there?
Let's see. Perry, 39-year-old male from Tempe, Arizona. I have swollen hands and feet quite a bit lately. I also have varicose veins. The swelling is pretty new. Any idea what I should have checked?
Basic things, obviously. What's your blood pressure? Are you hypertensive? How much do you weigh? Is the individual overweight? The more weight you put on the body, the more you're going to actually stress the body as well. How much salt consumption,
thyroid, is there
is it a metabolic etiology? You hypothyroid, there's all kinds of different things. I think the first step is if you have a primary care doctor, just get a basic checkup done.
Get your blood pressure checked, get some baseline blood work, make sure your liver function, your kidney function, all of that stuff. When I hear swelling of an extremity, if I hear unilateral swelling, I think of blood clot.
Right.
You know, that's the first thing. But it sounds like Perry here has swollen hands, so it's not
swollen legs.
and
He was
legs
saying
as
in
well.
varicose
Hands and
veins,
feet.
in hands
Yeah,
and feet. So
yeah.
when you're looking at more of a systemic problem, you wonder high blood pressure, you know, heart issues, you know, weight issues, metabolic issues. Those are all things that come to mind.
right, right.
Bart, and I believe he said Waukegan, Tennessee. So if I'm not correct, Bart, I apologize there. 48-year-old male was bit by a venomous snake 15 years ago. Since then, I get very sick all the time. Could heart damage from the bite make me totally run down all the time? Should I get tested for anything you can think of?
Off the top of my head, as far as venomous snakes in North America, you know, nothing. You know, there's certain like viruses like Chagas disease that you get bit by a tsetse fly in South America that has something called Trypanosoma cruzi, which can cause Chagas disease, which is a cardiomyopathy of the heart. In America, we don't really see Chagas disease, and as far as any kind of venoms that, you know, obviously venoms can have effects acutely on the heart, but I don't know off the top of my head of any toxin of any snake here that 15 years after the fact could have damaged the heart.
Right. I don't think so. Those of you listening that are in medical school or that are preparing for a board, Dr. Gaitonde just gave you an answer to a board question. You know, the Chagas disease and
Yeah.
Trypanosoma from the tsetse fly is a board question. So that's something
Show up on your
that-
medicine boards, might show up on your cardiology boards too.
Absolutely. That's good stuff. But getting back to Bart, you know, again, just a basic, you know, metabolic panel, get in to see your doc, make sure that just a general baseline blood work is normal. I think that would be the first step. Anything else, Joe? Okay, let's, do you believe we're almost done? The show's almost over? This has been great. This has been a very informative show. You know, talking about pacemakers and defibrillators, just for our listeners out there, just some tips that, household kind of tips. You already mentioned the microwave. You know, when you go through an airport, what are the things to think about? Battery life, you know, those kinds of things.
We did have the question from the chat person that sent this before the show. I didn't mean to interrupt.
Oh, good. Yeah, we'll get to that. That kind of follows in with...
As far as pacemakers, defibrillator traveling, as a question I get, and actually I pay attention to this more when I travel. If you look at any kind of metal detector when you're traveling, it says tell TSA if you have a pacemaker. Obviously, it's just like having any kind of orthopedic device. If you have a fake, you know, a replaced hip, or any kind of hardware, when you go through a metal detector, you're going to beep. Same with a pacemaker and defibrillator. Is that going to harm said device? No. A lot of times what they do is basically I tell my patients to wand on, you know, below the device and wand on top, you know, over, superior to the device, and show them. You know, every time I implant an individual with a pacemaker or defibrillator, they get a card that says I have a defibrillator or a pacemaker, and you just show it to the TSA, and it's not a problem. I had a patient, I put a defibrillator, and a week later he flew to Thailand for his son's wedding. So traveling is not going to be an issue with it, and you know, the TSAs are so familiar with it, it's not a problem.
Okay, so it's really not a danger to the patient. It's more that
No.
it's going to beep.
Yeah,
that
and
kind of
so
thing.
it's just maybe just, you know, save an extra 30 minutes, add extra 30 minutes when you're going through security.
Exactly. Well, you know, what about this hacking? Is it possible, you know, the defibrillators and the devices today are wireless?
Right. I guess, you know, anything technically, I guess, could be possible. But if you look at mechanisms as far as hacking devices in general, there is nowadays the devices are wireless. What that means basically is that information from said devices can be transmitted and can be monitored. So, for instance, patients of mine who have defibrillators, if they have any kind of irregular rhythm or something pops up, it will show up on my computer. So, as a flag, if it's something important, I can call in the patient earlier for evaluating. Now, as far as this information being available, you know, this is all secured information. Now, with this information, I couldn't, over the wire, I couldn't reprogram a device or turn a device on or shock a person. And actually, you know, as far as evaluating, I have to actually have the programmer right there by the patient, you know, with the physician present in order to actually reprogram or shock an individual. Now, can people receive inappropriate shocks? Yeah, depending upon how their device was programmed, who was the electrophysiologist who programmed it, but also things that can give you external noise. I tell my patients who have defibrillators, avoid anything that has a lot of electromagnetic interference, such as electrocautery, such as arc welding, such as working on a car with an alternator. Anything that gives off EMI can trick the device into thinking you're having a bad rhythm and thereby shock you. So there are all these kinds of guidelines that I instruct my patients after I put in a device, depending on what type of the device, to avoid for their own safety.
So those are the things to avoid if you have a defibrillator. What about a pacemaker?
Well, pacemaker also, it depends if you're pacemaker dependent. Like some individuals we talked about who have heart block, if they don't have the pacemaker, they don't have a heart rate. So therefore, if they're arc welding and they pick up this noise, the body's thinking, oh, you have a rate. We don't need to pace you. It'll stop pacing.
Okay, and that could be that could be dangerous. Yeah, so that's important to know. Joe, what else?
Bobby from Cape Cod. Is it safe to get an MRI or CAT scan? I have a pacemaker. My doc says it's no problem, but thought I would double check.
Very good question.
Good question, Bobby.
It depends upon the type of pacemaker. So defibrillators in general, we say avoid any kind of MRI, anything magnetic. CAT scans, X-rays are fine. The problem is that these leads can sometimes, the tips of the lead can get heated with these MRIs that can damage the lead. You can create noise on the lead. Sometimes if the patients are pacemaker dependent, they may not pace. Sometimes there's also been incidences of the programming of the device getting altered. As far as pacemakers, currently there's one company that makes an MRI compatible. Depending upon where you do the MRI, it's safe. And the next generation of pacemakers, you'll probably see pacemakers which are safe. But at the moment, there's no defibrillator per se which is FDA approved for MRIs. Now, there are some teaching facilities who I've seen do MRIs on patients with pacemakers and defibrillators, but usually there's a physician present in the room, and there's a lot of protocols based on that, but you don't see that routinely.
That's interesting. What other things would be contraindicated for any other testing? If you have a pacemaker and ICD. You can do echoes, ultrasounds. Anything else. X-rays, that kind of
X-rays,
stuff.
those are fine. But also, let's say they're undergoing surgical procedures. It depends. If you're using electrocautery in the surgery, if you have a pacemaker and you're using cautery somewhere in the chest area, that could potentially, depending upon how the device is programmed, can disrupt function. Or if it's a defibrillator, the patient might get inadvertently shocked. So so surgical procedures are not necessarily contraindicated, but you just have to prepare. Like anything in life, any procedure, you have to prepare ahead of time.
Magnets, they talk, the magnetic reprogramming of the pacemaker.
Well, so magnets basically have two different functions based if you have a pacemaker or defibrillator. Now these magnets aren't like refrigerator magnets. The ones I have in my office are like these heavy duty magnets. If you put one of those on a pacemaker, it's going to force pace the heart at a programmed rate. We call it an asynchronous mode, and the rate is based on the particular model as far as what kind of brand it is. If it's a Boston Scientific, it'll be at a certain brand, a certain heart rate.
Right.
But that will just pace you asynchronously at a set heart rate. Now, if you put a magnet on a defibrillator, what that does is turn off therapy, meaning it turns off the ability of the device to defibrillate the patient. It'll still work as a pacemaker, and that's not going to be altered, but it will turn off the shocking mechanism of the device.
One more question before we get to one of the guests. Cell phones, we have the iPhones now and the iPads and all that stuff. Is there a problem with holding it, maybe putting it in a pocket?
Well, I try to tell, because a lot of patients, like my dad, older patients will put their cell phone in the front pocket, which I'm like, just put it in your pants. Right. But there's anecdotal evidence that sometimes it could potentially disrupt it. That's why I usually tell the patients, just you can use a cell phone, just you just don't put it right above the device. Right. Put it in your pocket or put it in the opposite hand. Is it life-threatening? Again, it's been anecdotal stuff that we've seen that sometimes can disrupt the programming.
Right, and there are just some studies just talking about the iPad. Some of the covers are magnetic.
They have that magnet on it. Now, is that strong enough to disrupt a pacemaker or a defibrillator?
Probably not.
Probably not.
Okay, good.
Cindy Carlton from Fairbanks, Alaska. Another pregnant lady, 22 years old, and she said, please don't be upset if this question's dumb. Her husband's very upset that she called.
No such thing as dumb.
Absolutely not.
She said, I have a lot of heartburn, and I understand that's from what I eat. Does it affect my heart?
You know, obviously when you're pregnant, you have a little one in there pushing back, and it's very common to have worsening heartburn with pregnancy. Now, is that going to necessarily affect your heart? I wouldn't be super concerned. But of interest, actually, you know, people who have chronic coughs and reactive airway disease, sometimes they actually have reflux that goes back into their lung tissue, and that causes chronic cough. It causes, you know, respiratory issues as well. As far as a strict cardiac physiology, I'm not super concerned. Though of interest, you can have vaguely mediated arrhythmias, that people who have like stomach pains or too much acid production, sometimes that can cause a vagal effect and actually cause arrhythmias too.
But I think it's interesting, Cindy, the way she asked that question, you know, does heartburn affect the heart? I think it's a misnomer. I think
they call it heartburn, yeah.
Because it's in the area of where your heart is.
But
it really has nothing to do with the, you know,
for
with
the most
heart.
part, I wouldn't be concerned.
Right. The pathophysiology is acid reflux up into the esophagus, which sits in that area in your chest. So that's good. Thanks for calling, Cindy. That's good. You know, we just have a few minutes left. Anything else that you want to kind of talk about, or we want to just wrap up in terms of, you know, giving our listeners just some tips about electrophysiology? Again, maybe you can give us information about how, if anybody's interested in contacting you.
Well, if anybody's interested in contacting me, my office is right by Mercy Gilbert Hospital, right in the East Valley, and I go to pretty much every single hospital on the East Valley, as far as Casa Grande, actually.
Oh, right.
My car has a lot of mileage. My practice is called Arizona Advanced Arrhythmias. Again, that's Arizona Advanced Arrhythmias. The phone number is 480-398-3770. And again, information about me or just questions about electrophysiology in general, if you just go to www.AAAEP.net, AAAEP.net, it can answer your questions, frequently answered questions. What's an electrophysiologist? What's an EP study? What's an arrhythmia? A lot of answers, diagrams, pictures, information about that, and information about myself in the practice as well.
Good. That's great. Joe, do you have any questions or comments before we wrap up?
No. This was a wonderful segment.
Yeah, really good information. I want to just take the last couple minutes and talk about the continued care clinic that we have adjacent to the Gilbert Hospital. Especially coming up to Thanksgiving and Christmas and the holiday. What we decided to do was, you know, we see so many snowbirds in this area. Who come, maybe their primary care doctor is back in Indiana or back in Pennsylvania, and they come here, spend, you know, the winter, but don't have a primary care doctor. You know, if you do come to the hospital and if you're admitted and when we discharge you, if you don't have somebody to follow up with, we decided to put a continue care clinic where we can see you up to 3 times after your discharge from the hospital. Even those people that may have a primary care doctor, you can't get in to see them, you know, you can be seen there. And one of the things that we decided to do, because we got so many calls about, you know, insurance. We take most, if not all, insurances, but people that don't have insurance, who are cash-paying patients, we decided to, because we've partnered with St. Vincent de Paul and really helping the food bank and so forth, anybody that comes in, there's a set fee, which is really analogous to the Medicare fee. It's like $70, you know, for an office visit. Half of that goes to the food bank. And the other half goes to a pot that we have for people that may not be able to, you know, afford the blood work or the testing and so forth. So it's just something that we're doing at the hospital, and just wanted to kind of get it out there. If you don't have a primary care doc, if you need some pre-op testing, you know, those kinds of things, we would be more than happy to see you. And you'll be seen by a board-certified, you know, physician, myself, or, you know, we have another physician that's on staff there. So just wanted to kind of throw that out there and, you know, kind of put a plug in for the Gilbert Hospital. And soon at the Florence Hospital at Anthem, we'll have a continued care clinic as well. Well, Joe, I think that pretty much wraps up what we're doing. Those of you listening, we have a Facebook page. Please come on, like us. We have a DocTalkRadio.com, which is where you'll find all of the excerpts from these shows. We have now well over 200 excerpts from the DocTalk show on the website. It's DocTalk 1 channel on YouTube. I would love to hear from you. Next week, we have a rheumatologist going to be on the show, Dr. Deb Michael. I don't know if she's a colleague of ours in the East Valley. And it's going to be a very interesting show talking about rheumatologic problems, arthritis, rheumatoid arthritis, those kinds of things. So we have some great guests. Ross, thank you so much for being here.
Thank you for having me.
This concludes Doc Talk Radio with Dr. Ann Borick. Till next time, I wish you health, wellness, and many blessings.
DocTalk Radio is brought to you by Gilbert Hospital and Florence and Anthem Hospitals. Topics discussed are for informational and not intended to substitute advice from your personal physician.